Thank you very much, and thank you for having me here today. Internal pouch nutrition is something that is particularly close to my heart. It's an area, so I run a clinic, a virtual clinic, which is a nutrition and dietetics clinic supporting inflammatory bowel disease patients, but I also have a special interest in supporting internal pouch patients as well. And as well as my qualifications, I'm actually a pouch patient myself. I had a J pouch 15 years ago. Or J-pouch surgery 15 years ago. And I also, before that, lived with an ileostomy for 7 years. So I'm very, very passionate about supporting IBD patients and pouch patients, because I do think that there's a real missing piece of the puzzle in terms of nutrition guidance, but it can be the difference between someone, it can be such an important part of managing our pouch going forwards, and I'm going to cover that in our talk today. So I'm really delighted to be here and so happy to be sharing this information with you. Now, what is really important for me to say is that this is a massive topic and I've only got half an hour. So I've tried to squeeze as much as I can into it, but this is very much general guidance. If someone has, if one of you has a specific complication or issue, then it's very important to get personalized support and advice for you. And also my clinical experience is very much in internal pouches, in J pouches. So cock pouches isn't something I have experience in. So I think I might have to check with you in terms of what you might add at the end, if that's okay, in terms of the different advice, because I wouldn't want to be giving the wrong information. I think we've covered that, so that's fine. I have various ambassador roles and nutrition advisor roles, and run my own clinic, as I said, supporting patients. So what are we going to cover today? So we're going to be looking at why diet and nutrition are so important, and also nutrient deficiency risks that we need to be thinking about when we have pouch surgery. We're going to cover a little bit briefly about post-surgery nutrition, and then ongoing nutrition to support healthy pouch function and symptoms as well. Just by a show of hands, if you wouldn't mind, how many people are post pouch surgery? Maybe you can put your hands up. And anyone pre-pouch surgery? So going into it. Okay, so I'm not going to spend loads of time then in terms of just post-surgery, because that's not really relevant, but actually that's good because it leaves us lots of time to talk about other things. And so why are nutrition and food really important? So I guess first and foremost, it's to say diet is important for anyone, no matter whether you have a pouch or not. Every single person's diet is important because it can maybe increase or decrease our risk of certain lifestyle diseases, things like type 2 diabetes, cardiovascular disease. And so that's why it's important for the general population, but it's also really important to focus on when we have a pouch. Now, having a pouch can put us at risk of certain nutrient deficiencies. And the reason for this is our intestines are that big, long, wiggly tube, and the small intestine, which actually I think these probably show you quite well, is the wiggly bit in the middle that then the pouch is formed at the end. The majority of our nutrients are absorbed in that small intestine. So if you're using part of the end of it to form the pouch, so there's certain nutrients that are absorbed at certain places along the digestive tract. And if you're using the end bit to form the pouch, then the surface area for absorption of some nutrients is actually slightly reduced. And so that can put us at greater risk of some nutrient deficiencies. So it's something for us to be aware of. And I'll come on to what we need to look for in terms of symptoms and what we can do about that. Oh. I don't know why that's making that noise. So foods and drinks can affect the speed at which foods move through our small intestine and into our pouch. It can either help to speed it up or it can help to slow it down. Food and drinks can affect how much water is drawn into our small intestine and how much is absorbed out as well, which can affect how much we're going to the loo. And then also, this one is what's available for the microbes in our pouch to ferment. Now, the thinking is that diet is very important in terms of our pouch health, because you may have seen on the news or read about the gut microbiome or gut microbiota, which is everywhere at the moment. But the majority of that actually resides in the colon, which we obviously don't have as J-pouch patients or pouch patients. But actually what happens is a small colony of microbes colonize within the pouch, and they actually, the food that we eat provides them with their food, and when they feed on that food, they produce compounds which help to keep our bowels healthy. So it's really important that the research that we have at the moment is suggesting that it's really important what we're putting in terms of supporting the health of our pouch and the little microbes that live in there to try and help to keep it healthy. So all of those things that I've discussed are likely to play interacting roles together in the amount that we empty our pouch, the consistency of what's coming out, but also the pouch function and health going forwards. And diet can really play such an important role in helping us manage our consistency, but also other bowel symptoms that might come with that. So bloating, gas, pain, diarrhea, constipation. And that's where diet can really come in terms of improving quality of life. And something that I often see patients aren't guided on because there are a lack of services to support this and lack of specialist knowledge in the area. So nutrient deficiency risk in pouch patients, what is it that we're looking for particularly? So the research suggests that iron deficiency anemia is more common in patients with pouches. Also B12 deficiency, and that's because vitamin B12 is actually absorbed in the ileum, and that's where the end of the ileum is where the pouch is made from. So again, that surface area is decreased, so that's something that we need to keep an eye on. Vitamin D deficiency is also common, and zinc deficiency as well. So what do we need to be looking at in terms of how do we know if we're having problems with these maybe? And this is something to work with your nurses, on your GP and your surgical team. So if you're experiencing any of these symptoms, it's really worth getting tested. And actually it's a simple blood test that you can get through your team or through your. So I've listed the various symptoms there, but with iron deficiency anemia, it's tiredness and lack of energy, shortness of breath, heart palpitations, headaches, paler than usual skin. Now, I know some of those symptoms can also be caused by other things, but actually if you're worried about that, then it's really worth just having that blood test to check that. B12 deficiency can be tingling in your hands and feet, also psychological changes, a sore or red tongue, mouth ulcers, and reddening around the corners of the mouth as well. And then vitamin D deficiency, actually sometimes that comes with no symptoms, and vitamin D deficiency is actually really common in the general population in the UK, particularly in the winter months. And the recommendation is that everyone supplements with a vitamin D supplement during the winter months where we don't get any sun, because vitamin D generally is manufactured in our skin when it's exposed to the sun. But obviously, we don't get any sun in the winter. But if you're experiencing things like tiredness, but also bone pain as well, actually vitamin D deficiency is something that should be considered. And as I said, it's important for everyone to be supplementing over the winter months. And something I talk to my patients about often is that the guidance is to take it over the winter months. But what I tend to see with patients is even in the summer months, they don't get any sun exposure because either they're sitting in an office all day, so they don't get out in the sun, or maybe you're covering your skin up, or you're wearing sun cream, so you don't actually get that. So it may be appropriate for you to supplement over the summer months too. And then zinc deficiency, so loss of sense of your taste, poor wound healing, hair loss, and poor nail condition as well is actually something that we see a lot. So it's just worth remembering these and then having them tested for if it's something that you are finding that you're having a problem with. Then actually, in terms of B12 deficiency, it's something that's stored in our body, but our stores only last for about 3 months. So ideally, it's quite useful to have a B12 test pre-surgery and then to have one 3 months later, and to have them a little bit more regularly to start with, to see if that amount is dropping and those stores are dropping over time. Because if they are, then that shows that actually support might be needed. Sometimes, often, vitamin B12 injections are advised, because, again, as I said, if you take a supplement but you haven't got the ability to absorb it that well, but sometimes maybe sprays are recommended, but it's to be guided by your individual team in terms of what support you should get. So I'm not going to spend too long on this slide, but it is important in terms of leading to my next one. So post-surgery, so for 4 to 8 weeks, depending on what your surgical team has suggested, a low fiber diet is, kind of low residue diet is something that's recommended. What we tend to see in our clinic when we're seeing outpatients is that people don't then change their diet after that. So after that 4 or 8 week period, once you get signed off, you can actually then start to eat more foods in your diet. And we often find we see patients months, maybe years later, who are still following a very, very restrictive diet, which is potentially not helping their pouch symptoms, but also potentially increasing their risk of other lifestyle diseases later down the line. So it is really important to eat a healthy, balanced diet post-surgery, but in terms of how we're adapting this, so it's mainly based around fiber. And when we're talking about fiber, in terms of pouch health and supporting symptoms, generally the two types of fiber we talk about is soluble fiber and insoluble fiber. So I'm a big one for analogies, Simon is. So basically, soluble is dissolves in water, insoluble doesn't dissolve in water. The analogy that I think about is anything that collects in your sink plug hole doesn't dissolve in water and is insoluble. That's kind of a good way to kind of think about it. So actually, post-surgery, reducing or removing that insoluble fiber can be helpful. So in practical terms, that's like removing skins, seeds, pips, that kind of thing. So you've just got the fleshy bit of the plant that you're eating. So often post-surgery, things like melon, so really things with very small particle sizes that can pass through nice and easily, is what's recommended. But in terms of ongoing, as long as you have been signed off by your surgical team and they're happy for you, they're happy with how everything's gone, actually you don't need to follow that very, very strict low fiber diet going forwards as long as everything's okay. And again, I would caveat this with, if you have any complications, then this advice might be different for you, and it's really important to get that personalized advice. So in terms of ongoing dietary support post that kind of 4 to 8 week period, the research is showing that a Mediterranean style diet and fruit consumption with a J pouch is associated with a decreased calprotectin levels, lower rates of pouchitis, and better pouch microbial diversity. So I was talking there about the microbes that live within our pouch, and the more diverse those are in terms of the knowledge that we have around the gut microbiome, then the better in terms of supporting health. It's hypothesized that this is possibly due to the fiber content of the diet, which supports the microbial diversity and the pouch health, but also the antioxidant content, particularly of the fruit. Now, it's really important for me to say that there is some research in this area, but there isn't loads, and a lot of the studies we have are more observational studies, so we can't prove cause and effect of this. But what we do know is that generally suggesting that patients follow a Mediterranean style diet is safe for patients, and that it also has other health promoting benefits outside of the pouch. So until we have more very specific data, this is what is being encouraged for patients. Okay, let's go next. Just going to make sure that and actually what I think is really interesting is that what I see in clinic, but also what we tend to see in the research, is that patients often restrict diet to help manage symptoms, and often the diet is quite far away from a kind of pouch supporting Mediterranean style diet. But I think Simon brought up a really good and important point, which I experience myself, but also I see in clinic, is that everyone's experience with their diet, with their pouch, will be slightly different. So there's general advice that we could give to try and help to improve symptoms, but you might also individually all find that perhaps this one food, for a reason that we might be able to explain or a reason that we can't explain, really just doesn't work for you. And that's okay. And actually, I'm going to run through some foods today. It's really important that we're not restricting foods unnecessarily, where we can maybe just adapt them to help you tolerate them better. But it's also important that if we are restricting a food or a food group, that we're actually making sure we're getting those nutrients from other places, and that it's not really increasing your stress in terms of eating out and reducing your quality of life around food. So what does the Mediterranean diet actually look like? So it is consumption, this kind of helpful table here, which shows you consumption of fruits and vegetables and whole grains, nuts, legumes, olive oil. And then you've got kind of, that's what it's based on at the bottom in terms of mainly fruits and vegetables and whole grains. And then you go up and it's fish and seafood and a little bit of dairy, eggs, poultry, and then less of the meats and sweets. But I wonder sometimes when I'm talking to pouch patients about this, and when I spoke at another patient information day, we all kind of laughed a bit about it. Some people go like, that is so far away from what I feel like I can do with my pouch, or that is so far away from where I am now. And that is okay. What I really want to do is talk to you about actually how can we try and adapt this style of eating to suit your symptoms and suit your pouch. So how do we adapt it? So what I'd suggest is post that initial period post-surgery, but also if you've had your pouch for a long time and you really don't eat any of these foods, as long as it's safe for you to do so and you don't have any complications, then it would just be increasing things like fruits, vegetables and grains very slowly. So in terms of the data that we do have at the moment, it's looking like fruit consumption is potentially important in terms of reducing risk of pouchitis, and about kind of 1.5 to 2 portions of fruit per day may be helpful, but also actually is helpful for our overall health anyway. And so what I'd say is if you don't eat many of these things, then actually just increasing things very slowly can be helpful, because then we know what's working for you and what's not. But also we're not suddenly putting loads of stuff in that you're not used to, your pouch isn't used to, and then causing issues. So always low and slow with dietary changes. So small amounts and work up as well. So this can be really helpful in terms of building confidence, as well as making sure that we're not putting a huge amount of something that maybe doesn't agree with you in there and getting lots of symptoms. So a small amount. So for example, that might be like 1/3 of a portion or 1/4 of a portion the first time you have it, and then working up to a whole portion after that, just slowly over time. And then adapting textures can be really useful. So that can be cooking, removing skins, blending. So for example, so I can use nuts as an example here. So rather than whole nuts, I find that some patients find that whole nuts can be quite irritating as they come out, but actually it doesn't mean that you can't ever eat those things. Actually just blending them up, it's all about just reducing the particle sizes. So it may be that you have smooth nut butters, or that you put them into smoothies, or that you use nut flours like almond flour or something if you're doing any baking. Another example I can use is an apple. So there are kind of stages that you can use in terms of an apple. So first of all, I suggest like removing the skin and just having the fleshy bit. If that still you find doesn't really work for you, remove the skin and cook down the fleshy bit. So stewed apple sauce type thing. So it's much more easy to digest. And it may be that you find that actually the raw apple is something you don't tolerate that well, but actually the cooked apple is something that you tolerate okay. So it's all about finding these adaptations that mean that you can still enjoy and include these foods, but they're not going to increase your symptoms too much. And then focusing on this soluble fiber can be really useful. So that's the fiber that dissolves in water, and it forms a gel-like consistency. And it basically means that things move a bit more slowly through the bowel. It can help to reduce pouch frequency, and it can also help to form. So often what we see with JPAS patients is very watery stools, very watery output. And actually what we can do with the soluble fiber is that absorbs the water, forms a gel, and that can just thicken things up up for patients quite well. Now, often patients might be recommended to use some kind of fiber supplement. Maybe you've come across something called psyllium husk, which can be quite useful. It's basically entirely a soluble fiber, but we can find these soluble fibers in food. And it may be that you find the supplement helpful, and actually what we get from the supplement is just the soluble fiber. What we get from food is all the other wonderful nutrients that help to support our health as well. So there's ways that you can use one or either, or maybe both. It's about what's kind of you find most useful for you. So in terms of symptom triggers with foods, it's really important to remember that a pouch can take 6 to 12 months to settle. Am I right with that time scale in terms of that's what I tend to see? And it's really important that in terms of identifying any trigger foods or drinks, that we kind of adapt and swap accordingly rather than just removing completely. And I'm just going to run through some common symptom trigger foods. I'm conscious of time that I've been talking for too long. So coffee, we often see as quite a trigger food in terms of either increased frequency and sometimes more watery consistency. So actually, if you find that for you, actually perhaps swapping to other hot drinks instead, so you can still enjoy hot drinks. Some people find that maybe decaf's better, but generally, interestingly, in coffee, in terms of triggering bowel movements, it's not necessarily just the caffeine. There's other compounds in coffee which can trigger bowel movements. Spicy or chili food, or chili containing food. I know this is one, I know the kind of technical term is perianal irritation. I think a lot of us patients call it butt burn. That can be quite a tricky one. So actually, it doesn't mean that you need to have plain, bland, boring food. Actually, why not use more aromatic herbs and spices and fresh herbs as well, so you still can add flavour to your food. I've talked about nuts and seeds, so smooth nut butters, nut seeds, ground, milled nuts and seeds can be useful as well. If you find that milk, cream, and ice cream is something that tends to give you symptoms, it may be there's different components in dairy that's in dairy containing foods that some people might not be able to tolerate that well or might not be able to break down. So I always would encourage patients is don't just automatically remove that, because actually that is an important supply of calcium in our diets as well as some other nutrients. I always suggest that people try lactose-free versions first and see if that helps. If that helps, then great. It's the problem with just breaking down the lactose, which can sometimes happen after surgery. And if you're still finding that dairy really doesn't work for you, then maybe trying some alternative milks. But it's really important that you look at ones that are fortified, so ones that have added calcium in them. Oh. And then legumes, onions, garlic is something that I tend to see in clinic quite a lot. Perhaps some people don't find that they tolerate so well, or perhaps afraid to try. So blending these things into things like soups, using legume pastas, so mixing that in with the normal pasta that you'd use, and then really starting with very small amounts, like half a tablespoon or a tablespoon to start with, and then increasing that over a period of a few weeks can help to increase tolerance of those things. And something that's really important, I talked about particle sizes and breaking it down. So we can blend things, we can remove skins, those kind of things, but also we can mechanically break them down with our mouth. And I'm sure that chewing is something that lots of people here are aware of or have been told about, but that cannot be underestimated in terms of if you are having things with more textures and you're finding that the textures don't work so well for you, actually just focusing on chewing your food really, really well can really help. And I tend to find that actually helps quite a lot of people with their bloating symptoms as well, if that's something that you're experiencing. I know I'm running to time and I've only got one more thing to cover after this, but this is something that's really important is if you're having ongoing issues with certain foods, and particularly things like fatty foods, and also, as I talked about, there's lactose, or if you suddenly start experiencing an increase in frequency, urgency, pain, or changes in your pouch function, it's really important to speak to your GP or your surgical team and have further tests and investigations. It's amazing amazing maybe isn't the right word, but it's really sad the amount of patients that I see who come to me saying, I'm really having problems with my pouch. It was fine before and now it's not. And I then always automatically send them straight to have an investigation to see if that's pouchitis. And it's amazing the amount of patients who haven't been given a pathway post-surgery for what they should do if they do get pouchitis. I don't know if that's something that kind of nurse and surgeon wise you would normally do with your patients. Yeah. So I'm clearly not seeing your patients.
I think it's very much speaking to lots of other people, pouch owners. It seems to be very much a postcode lottery as to follow up. Certainly in Oxford, we do have a very structured follow up with our patients. I'm sure Richard does in Worcester. But speaking to pouch owners elsewhere, it can I've heard people who they've had their surgery routine surgical follow up and things, and then they're discharged and surgeon doesn't want to see them again. And that's quite sad. And they're sort of left their own devices, particularly, and then don't know where to turn to if they're having problems. So absolutely, if you're having problems, get a referral back to your local colorectal surgeon, and if they're not doing pouch surgery, then they can refer on to somebody who does pouch surgery. Yeah, whether that's a nursing team or a colorectal surgical team. Yeah,
and I think that's really important, is just having that pathway and understanding where to go if you are having problems, but also knowing that if your pouch function changes, that there might be something that's happening that can be rectified, and that really needs to be investigated so that you can have a better quality of life with your pouch. Yes.
One more comment on that is gastroenterologists. Gastroenterologists are usually very good at managing chronic pouchitis.
Yeah, I definitely see that with my patients. I work alongside lots of gastroenterology teams, quite a lot based in London, and they're generally really good in terms of seeing people quickly and then getting the right treatment. So that's really good.
And I'd just like to add that people that can't get seen locally contact IA.
Oh, there you go.
And they come to me.
Perfect. That's really good. That's a really good resource for me too.
Not that I can always help them, but I put them in the right direction.
Yeah, and I think that's really helpful. It's signposting in the right direction and knowing where to send people is really useful. Okay, I know I haven't got very much time. So just I couldn't talk about nutrition for pouches without talking about hydration, because it's something that's really important. So when we remove the colon, that's the organ that absorbs a lot of our fluids and a lot of water. So we really need to be focusing on this, and particularly post ileostomy surgery, the data's it's quite high in terms of readmission. The percentages are quite high in terms of readmission for dehydration post that surgery. So generally, our bowels do adapt over time, but particularly if we're very hot weather or we're doing lots of sport, actually we need to focus on hydration. So really useful tool is when you go for a wee, check the color of your urine, and what we want it to be is this more like the lighter the straw color, the better, basically. And if it's looking darker and the darker straw color, then it's a really good sign that you're probably a bit dehydrated. And then looking for these symptoms as well. And we can also see kind of dehydration, and that's something called salt depletion. So if you find that everything tastes very, very salty, then that is quite a good indication that you might be salt depleted, and that actually we need to really focus on getting you rehydrated, but rehydrated properly. So in terms of fluids, we should be aiming for around 2 litres of fluids a day, but maybe more depending on your weight or your activity levels. But also sometimes if we are dehydrated, drinking lots and lots of water actually can have the opposite effect in terms of hydration. So what we want to be doing is having something called an isotonic drink. So that can be things like St. Mark's solution, lots of people might have heard of, Diorolite. There's a couple of brands that you can buy online, SOS Hydration and Hydrostomate, which are specifically formulated, or Hydrostomate's actually specifically formulated to be like St. Mark's solution. So those things, when you are dehydrated, it's best to use those because we don't want to be having a negative effect. And sometimes if you just have plain water, it has the opposite effect and it actually can dehydrate you more. So that's really important. Some people I find in clinic, some people find that actually they're pretty fine on just normal fluids most of the time. And then when they're exercising or it's very hot, then they just pop in one of these day. Some people find that actually it's something that they do better on a more daily basis or a more frequent basis, because they seem to get less headaches and feel better hydrated. So it's an important point there, though. If you have diabetes, kidney or liver failure or any issues like that, then it's really important to talk to your doctor before taking oral rehydration solutions. And that's it. I know, sorry, there's so much to cover. I hope that that's given you a good overview and a synopsis of it. And I'd be really happy to take any questions if anyone has any. And thank you again for having me.
Thank you very much, Clemmie. It's actually technically lunchtime. And I know you aren't staying all day. What time are you leaving?
I have to leave quite soon. I'm
like
really sorry.
now.
It's like after. I'm happy to take questions, but then I'm really sorry I have to.
Yeah. I knew you were only here for a short period. So has anybody got any urgent questions? But I do just want to make a plug for the IA leaflets. One is called Staying Hydrated and one is called Looking After Your Kidney. And we've got them at the back, which says exactly what you've just said. Alison, you had a question?
I think it's important to talk about that. I was going to ask actually about the cock pouches and any additional information that you might want to add.
You covered it.
Yeah, staying hydrated. We've got a table over with lots of things, the hydroestimate, diurolite, things that you've mentioned.
Yeah, great.
Over there, all the leaflets, kidney, pretty much the same for a cock pouch that Clemmie's mentioned. What do you say, Richard? Yeah, you've covered everything really.
Okay, great. Good.
Yeah. Okay. Thank you so much.
Yeah, is this one working?
That's working. I can hear.
Yeah. I had to go out of the room for a short time and missed a couple of your slides, but when I came back in, you had one up that talked about the calprotectin levels.
Okay.
And I wondered if you had explained what these levels are and what it's measuring.
Oh, the fecal calprotectin.
Yeah.
Today, I don't know if I mentioned it. And fecal calprotectin is a marker for inflammation in the stool. And that's something that can be helpful to see whether someone has inflammation in the pouch or not. So it's used if you have inflammatory bowel disease. It can be used as a marker to check for flares and also to see progression in terms of how well medications are working for you. So that can be a really useful one. And it's something that I tend to send patients to their GP for. If they don't have a medical team supporting them, then I send them to their GP and say, can we do a fecal calprotectin? And then generally, if there's pouchitis, that does come back up as raised. And then they're referred to gastroenterology off the back of that if they don't have a team to go directly to. So that's a first step that can be useful to ask for if you don't have that supportive team, is to go to your GP. If they don't know what a J pouch or an internal pouch is, you can say, okay, so this is what I need. And then that can be, so it's a stool test. Super.
Are we all right to take one more, Carol? Yeah.
Can you say something about probiotics? Do they work for pouch patients or not?
Yeah, the data is very mixed in terms of pouch patients. I know that with probiotics that lots of teams used to recommend them post-surgery and now have stopped. I don't know, do you recommend probiotics post-surgery or not?
So I don't recommend them routinely.
Yeah.
But if somebody's running into regular problems with pouchitis, then VSL3 is the only probiotic that's actually got evidence behind it for pouch patients.
Absolutely.
So I'll say that again. So I don't recommend probiotics routinely, but if somebody is getting regular problems with pouchitis, then VSL3 is the only one that's actually got any evidence behind it.
And unfortunately, it's no longer available on FP10 prescription.
Neil? It's called Viva.
Well, they're different. Yeah.
Yeah, they had to rename it.
Big lawsuit.
And take something out.
Big lawsuit.
You can still get BSL3.
Yeah. I think it's again postcode lottery, and
it's not
basically
generally available.
That's exactly. So if I'm seeing patients that are having ongoing problems, or patients who are interested in potentially taking a probiotic to start with, probiotics we need to make sure that we're taking the evidence-based strain to help with the problem we're trying to tackle. There's no point in going to Boots and just buying something off the shelf. It's probably not going to help. So we need to make sure that we're using the evidence-based strain. And I think I can see a box of it actually over there. And it's the only one that I would recommend to pouch patients in clinic as well, is VSL3, now renamed as Vivo Mix.
We've all got the copy of the IA Professional, which is a professional website mainly for healthcare professionals. But this is, you can give it to your GP, and basically it will tell them Richard's sorry. Features. Yeah, sorry, I lost it a bit then. Richard features in a video actually saying what a pouch patient needs. There's a couple of patients with the cot pouch, a couple of J pouch patients saying what they need as a kind of, like B12, various things. And Richard literally just gives there's very good graphics, and just basically saying to your GP, ask how your patient's doing, the well-being, literally the whole well-being with the pouch. So this is really important. You've all got one.
Well done. No, that's great. Do you have anything else, Clemmie?
No, I think hopefully that answered the question about the probiotics. So yeah, I think that's it, unless anyone has any more questions.
I think we need to go to lunch.
Oh, there's one there.
Very quick.
Has there ever any
We'll get told off.
Sorry, that's my fault. I went a bit over time.
We do have to go to lunch.
Hi. Is there ever any focus on diet and food intake before it actually gets to the pouch? Because over the years, I've had horrific problems with food getting stuck in the small intestine. In fact, twice I nearly passed away. I get really, really ill. And I've been warned by my GP strongly that if these symptoms start again, stop eating, stop drinking, and get immediately to A&E, because the small intestine is going to burst. I've never been educated in that. I've never been told, but eventually they told me that it's because of the space created in the abdomen by taking the colon away. You get a kind of stiction effect, and the way I would describe the pain is it's like the Alien movie when the thing's going to burst through your abdomen. I've never felt pain like that in my life. I've had it about 6 times over the last 17 years, and it's just horrific. But when you're saying take the foods a different way, I just avoid them.
Yeah, and
I find it like Taliban's of food.
Yeah, Taliban's food. So this is something where I was saying, so you can, from surgical procedures for different reasons, get narrowings in the bowel post-surgery, or adhesions that then can restrict. Basically, if we think about the intestines as a food pipe, it just makes the food pipe smaller. So if you think about, I kind of think like square peg round hole. If you have too big a food particles trying to get through a small hole, it's going to get stuck, and then you're going to get back up, and then you get obstructions. So if that's where breaking down those particle sizes of those foods can be really helpful. So it's all about those particle sizes. If you have the big particles trying to get through a narrowed small hole, then you can get the risk of obstructions. So that's where, if you're finding problems with this, actually blending things, so soups and smoothies, removing those skins and mashing them. So for example, often things like carrots, cooking them until they're soft and then mashing them can be really useful. So those root vegetables, so you can still include them. Things like your apples, actually stewing them down, so those particle sizes are just super, super small. If you're having lots of problems, actually sometimes you can smoothie things. If there are still small particle sizes in there, you can then sieve them as well. It's a bit of a pain, I know, but it still means that you can remove all of those particles that might get stuck, but you can still enjoy the taste of those foods, still get the nutrients from them, and you don't have to exclude them from your diet so much. So it's anything in terms of strictures and obstruction risk. It's about breaking the particle sizes down, and it may be that you would be advised to follow a slightly low fiber diet, but it's removing that kind of roughy, insoluble fibers that don't dissolve in water. Does that help to explain that for you?
I think it's basically just common sense.
Thanks. Yeah.
There's a few food items. Well, that was an orange, and I created this thing called a bolus.
Yeah, food bolus that then
it was an orange that I ate, and it was abolished.
And then with the orange, you have the the white pithy
Violet,
skins. But actually, if you have things like melon that don't have the skins, they then break down and they're nice and soft. Then that's not really going to be so much of an issue anymore. So it really definitely is looking at those textures of those foods and just adapting those down.
Yeah, I'm smiling when you showed the Mediterranean diet because another food was squid. That nearly killed me.
Okay.
I was horrific.
And again, that's like the leathery, you're saying about squid, that's the kind of leathery texture. So again, things like, I sometimes find patients who have narrowings in the bowel, maybe things like steak and stuff don't work so well for them, but actually minced beef does work better for them. Again, it's about breaking down those particle sizes, and that can be really helpful for patients. And it's still because the thing that we have to remember with food is it is about nutrition, but food is also about taste, texture, pleasure, social connection. And it's such a big part of so many of our lives, and our quality of life can be massively reduced by not being able to include these foods. So I'm so keen to empower patients in terms of how can we actually include these foods, how can we enjoy them more, and also how can you help support your long-term health. So we're looking at pouch health, but we're also looking at, we see in ileostomy patients and in pouch patients, we often see increased risk of lifestyle diseases, so things like type 2 diabetes, cardiovascular disease and things. And actually diet is a way that we can help to try and reduce that risk for our patients, and that's really important for me. It's looking long term too.
Thank you, Clemmie.
I'll stop
We'll have
talking
to
now.
leave it there. It's really interesting, and we can go on discussing this later. But Clemmie, you've given us some really useful information. Thank you very much.
No problem.